Somewhere in the Amazon rainforest, a woman is about to give birth. There is no hospital within 300 miles, no doctor, no epidural, no sterile environment of any kind. What happens next has been happening in that jungle for thousands of years, and what researchers discovered when they finally documented it forced several assumptions of modern obstetrics to be quietly reconsidered. The Western world has spent decades assuming that childbirth in indigenous Amazon communities is dangerous, chaotic, and driven by superstition. The data tells a different story. Anthropologists and medical researchers who have spent sustained time embedded with Amazon tribes documented a childbirth system that is not primitive in any meaningful sense of the word. It is specialized, it is precise, and in several measurable dimensions, it produces outcomes that surprised the medical community when they were first published. The Kayapó people of the Xingu River Basin in central Brazil have maintained an unbroken tradition of midwifery that anthropologists estimate predates first European contact by at least 2,000 years. The women who perform this role, known within the community by a title that translates roughly as the one who knows the body, do not acquire their knowledge through a single apprenticeship. They spend years, sometimes more than a decade, observing experienced midwives before they are permitted to oversee a birth independently. The accumulated knowledge they carry covers not only the physical mechanics of labor and delivery, but an extensive botanical pharmacology that took Western researchers years to begin fully understanding. The use of plants during labor in Amazon tribes is not incidental. It is not ritual decoration applied to a biological process. It is a functional medical intervention refined over generations of observation and consequence. Ethnobotanist William Milliken, during field research conducted across multiple Amazon communities for the Royal Botanic Gardens at Kew in the 1990s, documented over 40 distinct plant species used by indigenous midwives during pregnancy and childbirth, each with a specific application, a specific preparation method, and a specific timing within the labor process. Some of these plants accelerate contractions when labor stalls. Others slow contractions when they become dangerously rapid. Several are used specifically to manage postpartum bleeding, a leading cause of maternal death globally, through compounds that promote uterine contraction after delivery. When researchers analyzed these plants in laboratory conditions, a significant number were found to contain biologically active compounds consistent with their documented effects. Several had never been identified in Western pharmacological literature before that analysis. The Yanomami midwife does not guess. She does not improvise. She arrives at a birth carrying specific plants selected in advance based on her assessment of the pregnancy over the preceding weeks, the position of the child, the condition of the mother, the progression of early labor signs. What looks from the outside like traditional practice is, in functional terms, a preoperative assessment followed by a prepared pharmaceutical intervention. And the births she oversees happen not in a dedicated space, but in the living environment of the community, which turns out, researchers found, to carry specific advantages that took time to fully appreciate. The position in which Amazon tribe women give birth is one of the details that most consistently surprises medical researchers encountering it for the first time. In the vast majority of documented cases across multiple Amazonian communities, women do not give birth lying down. They give birth upright, kneeling, squatting, or supported in a semi-vertical position by other women in the community who are present specifically to provide physical support during labor. This is not cultural preference, it is biomechanics. Research published in the European Journal of Obstetrics and Gynecology in 2017, reviewing outcomes across multiple studies, found that upright birthing positions are associated with shorter second-stage labor, reduced rates of assisted delivery, and lower incidence of severe perineal trauma compared to the supine position standard in most Western hospital births. The supine position, lying flat on the back, became dominant in Western obstetrics during the 18th century, largely for the convenience of the attending physician, not for the physiological benefit of the mother. Amazon tribes never adopted it, and the outcomes they achieve suggest they were right not to. The women present at an Amazon birth are not passive observers. Among the Shipibo-Conibo people of the Ucayali River region in Peru, the women who attend a birth perform a continuous physical and vocal support role that modern obstetrics has only recently begun to formalize under the term continuous labor support. Studies conducted by the Cochrane Collaboration, one of the most rigorous evidence review bodies in global medicine, found that continuous one-on-one support during labor reduces the likelihood of cesarean delivery, reduces the use of pain medication, shortens labor duration, and improves maternal satisfaction with the birth experience. The Shipibo-Conibo have been doing this without the research to tell them to for longer than recorded history. Then there is the Cuvade. Among several Amazon tribes, including documented communities of the Tupinamba and various groups across the Guyana highlands, the father of a newborn child undergoes a parallel ritual confinement that runs alongside the mother's labor and recovery. He rests, he fasts, or follows strict dietary restrictions. He avoids physical labor and in some communities remains in a separate space, performing specific behaviors that mirror, symbolically, the experience of the mother. In some documented cases, fathers report experiencing physical symptoms during this period: pain, fatigue, nausea, that have no physiological origin. Western observers encountering this practice for the first time have historically dismissed it as theater. Anthropologists who spent longer studying it reached a more nuanced conclusion. The Cuvade serves several simultaneous social functions that became clearer on extended observation. It publicly establishes the father's commitment to the child at the moment of birth. It removes him from activities that could introduce conflict or stress into the community during a vulnerable period. And it creates a formal transition, marked, witnessed, and socially acknowledged, from his previous role to his role as a father. Psychologists studying paternal bonding in industrial societies have spent decades trying to manufacture the social conditions that the Cuvade creates automatically: the formal acknowledgement of fatherhood, the community witnessing, the behavioral transition that is visible to everyone. Research on paternal involvement in early child development consistently finds that fathers who experience a clear, socially marked transition into parenthood show higher rates of sustained involvement in child rearing. Amazon tribes structured this transition into the birth event itself thousands of years before developmental psychology existed as a field. What looks, from the outside, like the father pretending to be in labor is actually a social technology for producing committed fathers. The mechanism is different from anything the modern world uses. The outcome is the same one the modern world is still struggling to achieve consistently. The naming of a child in Amazon tribes is not a formality. It is not a celebration scheduled for a convenient date after the birth. It is one of the most carefully timed and structurally significant events in the life of a tribal community. And the logic behind its timing reveals something about how these communities understand identity, belonging, and survival that the modern world has largely lost. Among the Yanomami, a newborn child is not named immediately. The naming happens after a specific period of observation, typically several days, sometimes longer, during which the midwife, the mother, and senior women of the community assess the child's condition, behavior, and physical characteristics. The name given is not chosen from a fixed list of family names or cultural traditions in the way Western naming conventions work. It is selected based on what the child demonstrates in those first days of life. A child who feeds strongly and sleeps with unusual stillness receives a name that reflects that quality. A child born during a specific weather event, or whose birth coincides with a particular animal sound or natural occurrence, may receive a name that connects them to that moment permanently. The name, in other words, is an observation. It is the community's first formal act of seeing who this specific person is. Anthropologist Jacques Lizotte, who spent over 2 decades living among the Yanomami and whose field documentation remains among the most detailed records of that community's social structure, noted that the naming ceremony functions simultaneously as a medical assessment, a social integration event, and a spiritual acknowledgement. The child does not exist, in the full social sense, until they are named, and they are not named until the community has reason to believe they will survive. This is where the reality of Amazon tribal life requires the most careful handling, because the same communities that developed sophisticated botanical pharmacology, biomechanically sound birthing positions, and psychologically effective paternal bonding rituals also made decisions about newborns that the modern world finds deeply uncomfortable to confront. In documented cases across several Amazon communities, including historical records of the Yanomami, the Tapirape, and certain Xingu River groups, infants born with severe physical conditions that the community assessed as incompatible with survival in that environment were not always kept alive. The practice, documented by anthropologists, including Marvin Harris, and more recently discussed in the work of Brazilian anthropologist Eduardo Viveiros de Castro, occurred within a specific cultural framework that is impossible to understand outside its context. These were not decisions made casually or without grief. They were decisions made by communities operating without any of the medical infrastructure that makes survival possible for premature or severely compromised infants in the modern world. There was no neonatal intensive care. There was no supplemental oxygen. There was no surgical intervention. The community's assessment of whether a child could survive was not a moral judgment about the child's worth. It was a medical prognosis made under conditions where the alternative to that decision was a prolonged death that the community had no means to prevent. Researchers who have documented this practice consistently note that the communities in which it occurred surrounded it with specific rituals of acknowledgement, ceremonies that recognized the child's brief existence and provided the mother with a formal process of mourning. The grief was real. The loss was marked. The decision was made within a framework that took both the child's reality and the community's capacity seriously. It is one of the most difficult truths in the anthropological record of Amazon tribes, and it is also one of the most important because it reveals something that the easier, more comfortable version of indigenous life stories tends to obscure. Survival in the Amazon has never been free. It has always had a cost, and the communities that have lasted thousands of years in that environment are the ones that face that cost honestly, collectively, and with more structural care than the word primitive could ever adequately describe. The ritual bath that follows a successful birth and naming ceremony is, by contrast, one of the most precisely documented examples of functional botanical knowledge in the entire anthropological record of Amazon tribes. The water used to bathe a newborn in an Amazon tribe is never taken directly from a river. It is never collected from rainfall without preparation, and it is never applied to the child's skin without first being treated with a specific combination of plant materials that varies by community, but follows a consistent underlying logic that researchers took decades to fully appreciate. Among the Kayapo, the postpartum bath is prepared using the leaves and bark of several plants, whose selection is the exclusive responsibility of the attending midwife. The preparation process begins before the birth. The plants are collected, cleaned, and prepared in advance, the way a surgical team prepares instruments before an operation. After the birth, the prepared solution is heated to a specific temperature assessed by the midwife through touch, applied to the newborn in a specific sequence moving from the head downward, and accompanied by a series of spoken words directed at the child that function simultaneously as the community's first formal address to the new person and as a vocal assessment of the child's responsiveness to sound and human contact. Ethnobotanical analysis of the plants used in these postpartum baths across multiple Amazon communities has consistently found the same categories of biological activity: antimicrobial compounds that reduce the risk of infection through the umbilical wound, the single greatest source of neonatal infection risk in environments without sterile cutting instruments, anti-inflammatory compounds that reduce swelling in tissue stressed during delivery, and in several documented cases, compounds with mild analgesic properties that reduce the newborn's stress response during the transition from the birth environment to the external world. The midwife preparing this bath has no laboratory. She has no chemical analysis available to her. What she has is a body of knowledge transmitted from the woman who taught her, who received it from the woman who taught her, in an unbroken chain of transmission that in some communities researchers estimate extends back further than any written record of the Amazon exists. She knows which plants to use because the knowledge of which plants work was purchased over generations by the deaths of children treated with plants that did not. What survived that process is not tradition in the decorative sense. It is evidence-based medicine in the most literal meaning of that phrase, practice refined by observed outcomes over the longest possible time frame. Researcher Elaine Elisabetsky, a Brazilian ethnopharmacologist whose work at the Federal University of Rio Grande do Sul focused specifically on Amazonian indigenous medicine, spent years documenting the pharmaceutical properties of plants used in Amazon tribal childbirth practices. Her conclusion, published across multiple peer-reviewed papers in the 1990s and early 2000s, was consistent. A significant proportion of the plants used by Amazon midwives contained biologically active compounds whose effects were consistent with their documented traditional applications. Several had never been analyzed by Western pharmacology before her research. Several contained compounds that became subjects of subsequent pharmaceutical investigation. The knowledge existed in the jungle long before the laboratory confirmed it. There is a tendency, when confronted with evidence like this, to romanticize it, to transform Amazon tribal childbirth into a symbol of natural perfection that the modern world has abandoned. That reading is as inaccurate as the dismissal it replaces. Amazon tribal childbirth is not perfect. Maternal mortality in isolated communities without access to emergency obstetric care for complicated deliveries remains a genuine risk. Conditions that are manageable in a modern hospital, placental complications, prolonged obstructed labor, severe postpartum hemorrhage, can be fatal in the jungle, regardless of how sophisticated the botanical knowledge of the attending midwife is. The system these communities developed is extraordinary within its constraints. It is not without constraints. What it represents, accurately understood, is something more interesting than perfection. It represents the maximum of what human intelligence, applied consistently over thousands of years to a specific problem in a specific environment, can produce without external technology. Every plant in that postpartum bath, every positioning decision during labor, every day of the father's ritual confinement, every careful observation in the days before a child receives its name. Each of these is the endpoint of a long process of human beings paying attention, remembering what worked, discarding what did not, and passing forward only what survived contact with reality. That is not primitive. That is the oldest form of science that exists, and it has been practiced quietly in the Amazon since long before the word science was invented.